Hey everybody, thanks so much for joining me today for my BFR with Women's Health webinar. Should take me about 30 minutes to get through this and about 45 slides. So my name is Ed Liccara. I'm the Director of Education for Smart Tools Plus. I've been doing this since about 2016 and have been using BFR for rehabilitation and fitness since about 2018, something like that. I wrote a book called Blood Flow, Dr. Licara's Approach to Blood Flow Restriction Training, and I'm in private practice in Dallas, Texas. So if you need to get a hold of me, feel free to use my socials or email me. All right, so what we're going to talk about today is why BFR works for women, hormones and recovery specific to women, navigating perimenopause and postmenopause, and clinical applications that you can start using right away. So before you get started in this, I want you to think about where are you right now in your journey? Are you wanting to build more muscle, but avoid heavy lifting? Are you dealing with joint injury or pain? Am I in perimenopause or postmenopause? Am I recovering from surgery or inactivity, or am I just curious about BFR? So, knowing where we are and then what the goal is makes it much easier for us to create a plan so we can accomplish our goals. What I want the trainers and the strength coaches and health professionals to really think about is we can't train women the same way that we train men. They're not just smaller men, typically. There's a lot of differences here. There's different hormone cycling, bigger highs, bigger lows more often. Recovery capacity can be a little bit lower. Joint sensitivities can be there. Right around the age of about 42, we start getting into perimenopause and then menopause and then postmenopause. Bone density issues because of those changes in hormones, and not just small changes like men. We get this gradual decline after about the age of 42 in testosterone and estrogen. Women are these drastic changes. I can see patients, we do labs in January, everything looks good, not menopausal or near it, and then 6 months later we rerun labs and estrogen drops, testosterone drops, LH and FSH are elevating, meaning that they're getting close or into menopause itself. And we'll talk about exactly what the definition of menopause is in a few slides. Muscle preservation can be more difficult. Post-surgical healing can be more difficult. Cardiovascular and clotting screening is important, especially those that have been on birth control or using synthetic type. Also, I should mention too is that GLPs, not that it's just women, but with GLPs, women tend to lose a little bit more muscle mass. And so we can use BFR with those that are on GLPs to help maintain or build muscle mass a little easier. But the bottom line is programming should be personalized around the person's goals, symptoms, tissue tolerance, and recovery, not just sex or cycle phase. So what is BFR? BFR is using these specialized cuffs that partially restricts blood flow into the limb, restricts venous flow out of the limb completely. That's a mistake right here. It's not partially, it fully restricts venous blood flow, meaning that the blood flow from the hand up back to the heart is completely restricted for a short period of time. This creates metabolites that accumulate in the distal limb, fatigues tissue faster, and helps to increase hypertrophy and strength signaling. Why this matters for women is very joint friendly, meaning you don't have to use heavy loads. You can, it's useful when we have these hormonal shifts, helpful for muscle preservation, bone preservation, and building. And it's a good bridge tool for when people are returning to exercise. Do we need women-specific exercises? Not usually. The exercises do not need to change because the patient is a female. Patterns stay basically the same. I tend to like loading in weight-bearing exercises for the bone density component. So squats and lunges, Bulgarian split squats, things like that. We modify when needed because of joint pain or tendon irritation, surgery or injury, low tolerance to heavy loading, mobility limitations, deconditioning, or weakness. So some evidence on menstrual cycle and resistance training, reviewing every major meta-analysis and systemic review to date. Colenso Semple and his group found no consistent evidence that menstrual cycle phase affects strength, performance, hypertrophy, or resistance training adaptations, meaning we don't need to adapt. We can be in a mesocycle or a short period of a training cycle, 6 to 8 weeks is usually what I recommend. And we don't have to alter that based on where in the menstrual cycle we are. So this has been kind of inconsistent. There's been some evidence that like young women have more risk for ACL injury around their menstrual cycle, but it doesn't seem to affect the actual training that we do. So we don't have to worry about it as we're programming. Hormonal cycling and training adaptations. The hormonal cycling may influence energy levels, sleep quality, pain sensitivity, perceived exertion, fluid retention, recovery rate, motivation, training tolerance, mood and focus, and exercise duration. So we need to play around those times. But we just meet people where we're at like we always do. When do we actually modify training? We're not going to shift it just based on cycling. We're going to change the plan when there is joint or tendon pain, post-surgical status, mobility limitations, deconditioning or weakness, clinical contraindications, or clearance restriction. What changes a specific day with my training with my patients is if they are having a high symptom day, poor sleep or recovery, unusual fatigue, high perceived exertion, or pressure sensitivity or cramping. So when we're managing high symptom day, we're just going to reduce our total reps and sets. Maybe we reduce load a little bit. Maybe we just make it a recovery day. It's okay. It's more about the consistency and training through these things than having to actually stick to a set plan. What's interesting, pressure tolerance can shift across the cycle. There was a 2025 pilot study looking at sensory and pain electrical thresholds, and they were significantly lower in the premenstrual phase across all participants, meaning less stimulation was needed to feel pressure or pain. So we could have higher sensitivities at certain times of the month. So we just have to be aware of that and just train through it. Clarifying the menopausal timeline. So premenopause is defined as reproductive years before the menopausal transition begins. Perimenopause is that transition leading up to menopause. Menopause is defined as 12 months with no menses. And postmenopause is a stage beginning once menopause has been confirmed when we've had that 12 months. So here's a nice little graph showing this. The important thing is to keep training, even those that have high premenstrual or menstrual cycle symptoms. Exercise appears to help with those symptoms. So kind of just train at a lower intensity. It looks like any intensity works. Consistency was the key. And really just keeping sugars low and exercise helps that, can really help those menopausal symptoms. Not menopausal, sorry, menstrual cycle symptoms. Perimenopause, the transition window. What we have to know is that as these hormones are shifting, training is going to be a little bit different. Our body's going to respond a little bit differently. Our recovery might not be as good. We might collect more visceral adipose tissue around the abdomen. That's usually an estrogen dominance, meaning testosterone is dumping. So those need to be looked at. Usually I'll run labs, see where those hormones are, and then either try to make non-pharmaceutical intervention or do pharmaceutical intervention to balance those hormones. But it's really important. We basically have ignored perimenopause and menopausal symptoms for years and years and years. And I think now over the last year or 2 years, there's been a higher awareness as a medical provider to try to help women transition through this more easily with hormonal balancing. The joint pain jump, there was a meta-analysis of 37 studies, 93,000 women across 22 countries, and they looked at what pain levels were. This is how the distribution is. Women in menopause, perimenopause, or postmenopause. Perimenopausal women had a 1.35 time higher risk of joint or muscle pain than premenopausal women. The risk was similar between perimenopause and postmenopause, pointing to perimenopause as the inflection point, not a gradual climb. So those joint irritations are normal. It's a lot of it between this shift in our hormonal balance. In postmenopause, muscle supports metabolism, joint support, balance and fall risk, and long-term health span. So we want to try to maintain this muscle mass throughout our life term. And that's both for men and women. And muscle really does matter. Muscle is the number one way that we deal with sugar. Muscle will pull sugar into into the muscle to be utilized. And so it gets it out of the systemic system, reduces your overall insulin tolerance, and just helps overall health. So we want to make sure that we're maintaining this muscle mass over time. BFR is high leverage for women. It's bridging the gap between what the body needs and what it can currently tolerate. So um, common training priorities are strength stimulus, muscle preservation, bone health support, metabolic support, and a joint friendly approach. And BFR provides all this, meaning we can use low loads, get the benefits of high load training without overstressing the joints. Heavy resistance is recommended when appropriate and tolerated, but BFR provides a low load alternative when heavy lifting is not possible. Fasudovin and Ford in 2022 wrote a paper regarding heavy weightlifting, and because of joint pain, sometimes it's not accessible or usable or able to. So using the BFR with low loads can be a nice alternative when necessary. So asking yourself this question, which concern do you hear most often? I feel weaker than I used to. My joint hurts when I lift heavy. I'm worried about bone density. I'm losing muscle while trying to lose weight. I don't know where to start. So think of yourself, what do we hear ourselves talking to? What do we hear inside of our brain? But also, what do we hear other women and your groups of women or your clients or patients reporting to you as their biggest problem? And I think for me, I would say bone density is number one. And then number two is trying to maintain their muscle mass and strength. With bone density and muscle preservation, we're going to train these together. BFR can support muscle mass maintenance, functional strength, balance improvements, fall risk reduction, exercise consistency, and with the bigger goal of having better function, long-term independence, confident movement, healthy aging, and quality of life. BFR does not replace osteoporosis medical care or osteopenia. Impact and weight-bearing exercise for bone health, heavy resistance when safe and tolerated, adequate protein and nutritional intake, and provider-supervised planning. BFR complements these things. Sa et al. In 2025 examined the effects of resistance training with or without BFR on bone metabolism in osteopenic women. And what they found was that when they completed 8 weeks of training twice weekly, low intensity BFR training produced strength gains statistically equivalent to high intensity resistance training. So we're able to use those low loads as long as we're using BFR to get similar effects of using high load training. So you say, is it a good alternative? And the answer is yes, BFR can be a very good alternative when we look at studies like this comparing the two groups. For postmenopausal women, it's very feasible in untrained women. Twice weekly, 8-week protocol was well tolerated by physically inactive participants starting from a sedentary baseline. So if you don't have a huge history of weight training, we can use BFR in light loads in order to get the effects that we're looking for. And according to Wang, he found that low intensity BFR raised bone formation markers in older adults, though to a slightly smaller degree than high intensity. So again, if we can lift heavy weights, we want to lift heavy weights, but if we can't, then BFR is a nice alternative. Another meta-analysis of BFR training and bone health by Liu, low load BFR versus low intensity training alone. BFR was statistically significantly better. Low load BFR versus high intensity, there was really no difference in bone density gains. So more studies need to be out there, but we know that BFR with low load and high intensity training. And I should define high intensity training. High intensity training is lifting between 65 and 90% of your 1 rep max. So much heavier loads than what we're talking about with BFR. BFR is 20 to 35% of your 1 rep max. So much lower resistance. So we talked about this study, this 2025 study, 3 or fewer sessions per week produce better hormone response than more frequent. So 2 to 3 times a week is what I recommend with BFR. It doesn't have to be more often than that. We need to recover just as much as we need to lift. So a simple sample BFR protocol might be 2 to 3 sessions per week. Your rep structures are going to be 30, 15, 15, 15 with a 30-second rest between sets. And you're going to individualize your pressure, meaning when I put the cuff on my limb, I'm going to increase the pressure to about 40% of your limb occlusion pressure. And if you're not sure what that means, go back to some of my previous webinars where we talk about limb occlusion pressure and individualized limb occlusion pressure. Some exercises that I really like: leg press, sit to stand out of a chair, hamstring curls, knee extensions, glute bridges, hip thrusts, all very good. I like to mimic real life activities like getting off the toilet, getting in and out of a chair, um, with my training protocols. So that way we can continue to do those throughout our lifetime and lifespan. Low load BFR protocols for muscular endurance and work capacity goals. So again, frequency is about the same, 2 to 3 times per week. Rep structure is the same. Rest periods are the same. Individualized LOP. The goal here is to improve fatigue resistance, training tolerance, and exercise capacity using lighter loads and simple aerobic work. So step ups, very difficult with BFR, but you're just using body weight. Sit to stand out of a chair, very good. Calf raises are great. Glute bridges, hip thrusts. Again, sample BFR for fall risk reduction and balance support. Doesn't really change. BFR is basically, no matter how we're utilizing it for strength, or muscle mass, it's basically the same. We just kind of change up a little bit with how we program. Again, very similar type exercises. We can also use BFR just with walking or being on an elliptical. You're doing between 5 and 20 minutes total. And what's nice about BFR walking is that it takes a low intensity exercise, walking, and it creates a physiologically adapting exercise. So what we've seen with studies, even in athletes, that if we put the cuffs on our lower limbs and we go for a 20 to 30-minute walk, what it does is it makes that walk physiologically demanding to the system. And so you increase muscle mass and size in the lower extremity while building aerobic capacity, which you normally wouldn't do with just regular walking. You can do you can do bike or a seated stepper. You can do treadmill walking or outdoor flat walking. So what BFR should feel like: screen carefully for history of blood clots, uncontrolled hypertension, cardiovascular disease, vascular disease, pregnancy or early postpartum, active cancer, severe neuropathy, post-surgical without clearance should not be performed, and unusual limb swelling. Normal pressures, you should just have a pressure sensation when you have the cuffs on, a little bit of muscle burning, but in a good way, local fatigue, and you'll feel a pump of the muscle. Not normal is numbness, tingling, sharp pain, dizziness, limb discoloration, symptoms that persist, or worsening pain after. Anybody that has varicosities or varicose veins, they should monitor those to make sure those don't get worse with repetitive training. BFR should feel challenging. Stop and reassess if red flags appear. So what's your biggest takeaway today? Is it that BFR can help build strength with lighter loads? Is it that BFR may be especially useful during perimenopause and postmenopause? Is it that BFR can support post-surgical recovery? Is it that BFR may help protect muscle during weight loss? Is it that BFR should always be individualized and screened? So in your mind, what's your biggest takeaway from today? My final takeaway is we just want to train smarter, not just harder. BFR may support muscle preservation, strength and lighter loads, joint-friendly training, training around perimenopause, postmenopause, and healthy aging, bone health programming, post-surgical or deconditioned return to exercise, confidence building without heavy weights or complex gym routines. And BFR does not mean you need completely different exercises. The goal is to use familiar, well-chosen movements and adjust the session based on pain, recovery, readiness, and safety. So what's next? Every month I do one of these. Next month I'm going to talk about low back pain with core engagement and BFR integration. Here's my contact information if you need any help with programming or you want to do an individual session with me regarding getting set up with BFR or how to do BFR. And here's some of my references in case you're curious. I do have a BFR bootcamp. You can scan the QR code. This is for individuals that are not health professionals or strength and conditioning professionals. So you're just a normal person, you want to get interested in BFR, I have the BFR bootcamp. I also have professional certifications, level 1 and level 2. You have to take level 1 before you take level 2, but level 1 is foundations for strength and conditioning specialists, athletic trainers, chiropractors, physical therapists, occupational therapists, and then level 2 is for clinical and performance applications. And then I also have an instrument-assisted soft tissue mobilization course. And those are all on the smarttoolsplus.com website. So here you can scan for the BFR professional certifications. There are continuing education, depending on your state, available with these courses. Here's my YouTube channel and my Instagram. Feel free to scan those and follow along. If you've learned anything today, please like and share. We do have numerous cuffs available are Gen 3 cuff. These cuffs get put on. We use a separate pump and Doppler to measure your limb occlusion pressure, and it detaches, so you're not tethered to the pump end. And then we have an app-based one as well. That's our Gen 4. And just for being here, you get an educational discount on anything on the website. Just use the code education10 when you check out. All right, thank you so much. I will see you next week. If you have any questions, please reach out. Bye for now.